Good morning. Thank you very much for the invitation. This is my disclosure. So basically, when we speak about BTK and foot arteries angioplasty, the main purpose of this procedure is the wound healing. And healed wound means walking capability salvage, which is really completely different from limb salvage. But we have to manage and we have to approach this topic with two different populations of patients with chronic limb-threatening ischemia. And Dr. Roberto Ferraresi showed us very punctually the difference in this patient. When we have a big artery disease, we can do almost everything in this patient. The outcome will be very good. And when we have patients with a small artery disease, probably the outcome will be very bad. Let's have a look at the patient. This is a patient, of course, diabetic, with a gangrene in the second toe after amputation of the first. This is the angiographic aspect, and for sure we have a big artery disease. After the recanalization of the complete recanalization of the foot of the leg with a very good perfusion angio results, we achieved the first target, the bleeding during the surgical treatment of this lesion. But the rationale to be aggressive with this patient is that when we have an infection or a wound, we need a lot of blood flow to improve the wound healing process. And we need a patency at least of 150 days, so a little bit less of 6 months. Otherwise, if we have a stop during this process, we need a new treatment. But again, when we have this kind of patient with what we call big artery disease and we achieve a good revascularization, it's possible to, with a strict follow-up, to achieve a wonderful wound healing process with no recurrences after 2 years, despite the TCPO2 is less than in the beginning. So probably some arteries are closed now. The same with this patient, complex lesion, a little bit of calcium, almost dessert food. With an aggressive preparation of the vessel, we can achieve this kind of angiographic result. And this, again, it's a description of what we can achieve. No clinical restenosis after 2 years, again, in this patient. And again, a lady with a complex foot situation, but big artery disease, we can be very aggressive, a lot of blood, and we can achieve 5 years no recurrence in this patient, still walking now 9 years. So what we have to distinguish, what we have to look for is the kind of disease. It's different in this kind of patient. You can see a necrosis, a gangrene of the first. This is a small artery disease patient coming from another country with a very poor outflow. Of course, again, in this patient, it was possible to achieve an acute revascularization aspect acceptable. You can see the blood flow after the procedure could be considered acceptable. But the next day, he went into the operatory room for the amputation of the first and the graft, but something happens. After 7 days, we have this aspect on the foot, and so we had to modify the amputation program and again modify and shorten, and again we arrived to have a major amputation below the knee. So this is what happens when we have the small artery disease patient. So in conclusion, the durability of below the knee and foot arteries intervention probably is enough for wound healing in the most of cases. High rate of walking capability salvage, we achieve 87% since 2003. And actually, we only have 13% of clinical risk stenosis that needs a new treatment. Maybe drug-eluting balloons can reduce the number of retreatment in this part of population. Thank you very much for your attention.